Okay, so we've passed 500. I'm probably going to go ahead and get started then. Thank you to everyone that has joined us today for this panel, which is about neuroracism. Essentially, we're going to take you through all manners of the neurosciences, look from AI to pain management, and really just give you a scope and idea of how our science is, in a lot of essences, not apolitical and how it can be used and weaponized against Black people. So I want to say, firstly, thank you to all of our sponsors who have joined us, who have made this event possible. And then secondly, to all of our speakers who we have today. So I'm just gonna introduce you all in turn. So firstly, we have Dr. Danielle Doyle. Secondly, we have Tony Black. We have Jordan Harrod. We have Dr. Oliver Rollins. And we have Dr. David Hodge. And it's very nice to see my co-host, Taya Riggins, has joined us as well.
Yeah, sorry.
So I'll very quickly introduce myself. My name is De-Shaine Murray. I'm a second year PhD student at Imperial College London. And I'm studying in the field of neurotechnology. Taya, if you don't mind introducing yourself.
My name is Tia Riggins, and I'm a PhD candidate in biomedical engineering with a focus in neuroimaging at Michigan State University.
Okay, thank you. So what I find is very interesting whenever we go to talks like this, there's often a moderator or a host that gives a really long intro into whoever the speakers are. But I'm not going to do that today. I'm going to ask you guys to all introduce yourselves. So firstly, I'm going to ask Tony, if you can give us a quick 2-minute intro into yourself and your career and really briefly summarize your career to this date.
Sure, not a problem. Thanks for having me. First of all, can you hear me okay?
Perfectly.
Yes.
All right, great. Good morning. At least it's morning here in Chicago where I am. My name is Tony Black and I'm with IBM. I began my career over 25 years ago in IT, and I've been in healthcare IT for the past 10 years. I'm currently the communications officer and secretary for the National Society of Black Engineers Healthcare Innovation Group, and I'm the vice chair for the Professional Certification Board for HIMSS, which is the Healthcare Information Management System Society. As I said, I began my career over 25 years ago in IT and have been flourishing in IT ever since, going through newer technologies, and I'm currently working in cloud technologies at IBM. So that's where we are today. Thank you.
Lovely. Next, we're going to have Jordan. Can you please introduce yourself to us?
Hey everyone, I'm Jordan Harrod. I'm a rising third-year PhD student in medical engineering and medical physics through the Harvard MIT Health Sciences and Technology program. My research focuses on using brain stimulation for clinical anesthesia, as well as developing non-invasive and minimally invasive brain stimulation devices and machine learning for controls and neuroimaging data. Outside of that, I do a lot of work in science communication, science advocacy. So I have a YouTube channel where I talk about the ways that we interact with algorithms in our daily lives. And I'm also the chair of the MIT Graduate Student Council's External Affairs Board, which deals with local, state, and federal policy advocacy for issues that impact grad students.
Lovely. Next, can we have Dr. David Hodge, please?
Good afternoon, family. I hope everyone is well. My name is David Hodge. I am the Associate Director at the National Center for Bioethics in Research and Healthcare at Tuskegee University. My research interests includes xenotransplantation, includes neuroethics and neurotechnology, includes what less of a research interest and more of a concern, fixing the nomenclature that has been given to the so-called Tuskegee syphilis study, when it's really the United States Public Health Service syphilis study at Tuskegee. So we're trying to make sure we shift that narrative and correct us to the dialogue. We are very interested in amalgamating public health with bioethics and neuroethics to ensure that we are stopping or preventing or bringing into conversation as much of the the injustices and violations that have been taking place. A major concept that we push is a notion of trustworthiness over trusting. It's hard to trust someone if those that you're trying to trust lack trustworthiness. So that's basically who I am. I'm a philosopher by training and a theologian by training. My first doctorate degree is in theology. I have a PhD from University of Miami in philosophy.
Perfect, thank you. Next, to introduce yourself, please, can we have Dr. Danielle Doyle?
Hi, and thank you for having me. My name is Danielle Doyle. I'm an assistant professor at George Washington University Hospital. I've been here for about 6 years. I practice pain management with an interest in neuropathic pain, complex regional pain syndrome, fibromyalgia, and migraine. I trained at Howard University for undergrad and University of Maryland for medical school, and I'm interested in advocating for better access to pain management for all patients, including Black patients. Currently in pain management, it's a field that's close to 90% men, and less than 3% of the providers are women. So it's definitely an area where I focus on advocacy work.
Perfect, thank you. Last but not least, Dr. Oliver Rollins.
Thank you, De-Shaine. So my name is Oliver Rollins. I'm an assistant professor at the University of Louisville in the Department of Sociology. So I'm a sociologist by training, but my work tends to focus kind of in the area of science technology studies. I'm really interested in the ways social cultural dynamics impact kind of the production and their social value, or what we think about as the social value for neuroscientific technologies. And I'm also really interested in, of course, in the ways in which race and racism impact both the production of neuroscientific knowledges and the ways in which we think about their use or think about their potential use within society. We'll probably talk a little bit more in the questions, but I have a forthcoming book on neuroscientific technologies that look at, or neuroscientific knowledges, that look at antisocial behavior. And I'm, of course, looking particularly kind of one of the ways in which kind of race informs or not that research. And then the project that I'm focusing on now is thinking about how neuroscientists study implicit racial bias and the potential benefits or consequences of thinking about race at the neurobiological level in that way.
Perfect, thank you very much. And just quickly, I did have a question in the chat. Jordan, can you shout out your YouTube again, please? We already had a request.
Oh, it's just my name. You can just look up my name.
There we go, perfect. Okay, so the first question we have is actually going to go directly to Dr. Doyle. So we've briefly summarized careers, but in terms of neuroscience, I actually want to go into pain management and in general. So here in the UK, and I'm not asking you to give the UK context, we have an issue or a phenomenon that we see where Black women are 5 times more likely to die in childbirth than their white counterparts. And I know that there are very similar stats in the US. I think it's up to 2.5 to 3 times more likely. So can you please give us a little comment on that and comment on this disparity and what you've seen?
So this is a major health disparity that you just mentioned. Mortality or deaths are up, widely in the US. However, Black women are more than 3 to 4 times more likely to die giving birth or in the period immediately after giving birth. And the disparities don't stop there in the peripartum period. So Black women are 2 times more likely to suffer from infertility, 2 times more likely to be diagnosed with postpartum depression. Infant mortality in Black infants is much higher than in their white counterparts. And a lot of this boils down to the history of systemic racism within medicine and the attitudes and procedures that have been taken against people. In a recent study, it's shown that up to 1/3 of Black women can account for instances of discrimination in a healthcare setting, and that nearly 20% of Black women are afraid to go to the doctor. They're afraid of being re-traumatized, and they're afraid of being exposed to bias. So definitely maternal mortality is one facet in a multifaceted problem that involves medical racism and access to care.
Wow, thank you for that answer. I'm going to actually throw this out to anybody else on the panel. Does anyone else have a comment at all as to what Dr. Danielle has just said? If not, I'm actually going to stay with you, Dr. Doyle. So
Sure.
With that, have you yourself actually seen any differences in treatments with regards to that being assigned to Black patients compared to white patients in your own career?
Well, in my own experience, just as a Black woman, as a Black family member, as a Black mother, as a Black daughter, I've, even before being in medicine, you could see the differences that are taken. So I've had to advocate for myself after surgery, for my family members after surgery to have adequate pain medicine. So it's something that is so written into the system, written into the programming of our healthcare system and of our society, that it's probably easier to find things that are not, that aren't biased than that are. Or vice versa. There's a long history with pain management regarding Black patients. I mean, you could take this all the way back if you wanted to look at the 1619 Project with Nicole Hannah-Jones talking about, the first time that an enslaved African person, came to our shores. That's really when the Black American pain experience started. And unfortunately, not much has changed since that time. The whole cornerstone for the mistreatment of Black pain is based on the idea that Black people do not experience pain in the same way. And so there are multiple ways that this affects us. So there's the idea that we are subhuman. And then there's also the idea that we are superhuman, that we are stoic with our pain. And so there's a wide body of evidence that supports that Black people get less pain management, pain medications. They're less likely to get referred for physical therapy. They're less likely to be prescribed opioids and medical cannabis. And it's a wide-ranging problem. If we go back to the early 19th century or mid-19th century, and we look at what is called plantation medicine. So essentially, this is what was used for people, enslaved Black people who lived on plantations. And if you look at the roots of their healthcare, and you can see the parallels today, where healthcare was provided based on your labor output and what could be taken from you, not necessarily for your own benefit or for your own pain control. And we are talking about we're talking about Marion Sims, who was formerly regarded as the father of gynecology. He was a very famous doctor who performed many of the basic gynecologic surgeries, C-sections on enslaved Black women without anesthesia. And mind you, at that time, there was anesthesia available. That was a choice. And a lot of those procedures were forced on women who were Black. They could not consent, they could not refuse. And then once they perfected those techniques, then they used those techniques with wealthier white women with anesthesia. So if you look at our healthcare system now, you can kind of still see that parallel, that our healthcare system, if you lose your job, most instances you lose your healthcare. And these have far-reaching roots. It's not a new thing. It's not a bug, it's a feature. It's how the system was made to operate.
That was an amazing response. I was just thinking with that and everything that's going on, how do you address, personally, within your practice, these myths, and how do you kind of comfort, Black women in their journey with health?
So I think that the initial thing is you have to have a trauma-informed approach to Black patients and really to all patients, you should be assuming that there's some sort of trauma there. And so when we talk about trauma-informed care, we're talking about asking patients permission, giving them information about who they're seeing, why they're seeing, asking permission before you see someone, all the way up until how do you document that patient? When I was in medical school, it was common to, as in our history of present illness, the very first thing you would say about a patient is their name and their race. And we are no longer ascribing to that. We're no longer saying that it's okay to treat race as an indicator for genetics. So race is not a risk factor. Racism is a risk factor. And I think, a lot of times patients, especially Black women or other patients, when they come to see me, they've been in pain for quite a long time. And so there's a lot that we have to do to build rapport, build trust. And, with the COVID-19 epidemic, there's been an increase in telehealth, which is a great option, but it causes us to have to reach out even more kind of through video to try to capture some of those same issues.
Wow. Okay. Thank you for that. I'm actually going to, it's not switch tack, but actually try and bring Dr. Hodgin. So you are at Tuskegee at the moment. So with regards to Tuskegee, we know the history and the legacy of Tuskegee and the experimentation that was done there. So for all the views that we have here, or who may be international or may not know, can you actually explain a little bit about what happened with the Tuskegee syphilis experiments?
Thank you very much. Good to be here. Thank you for everyone who's signing in, and thank you for the conveners who have given us this opportunity to have this marvelous conversation. Thank you, Dr. Doyle, for that presentation that you just gave. Let me step back. I did want to give an ethical response. I'm an ethicist by training, and that's what I bring to this conversation, because I don't know anything scientific. All I know is to raise questions about whether or not those things that are being done and utilized, or whether or not they are actually based in some ethical construct. And some ethical constructs can actually be harmful and divisive. If you take a utilitarian approach, for example, it could be extremely harmful if you don't take into consideration all of the particular factors that will bring about a useful utilitarian argument. However, just a moment on J. Marion Sims, who I found to be a very interesting figure, mainly because on the ethical side, that there's so many people who feel justified in defending Dr. Doyle, his methodology, even though, as you said, that there was anesthesia available, but he chose not to use it, and then had the caveat, well, they weren't feeling pain. Well, when you look at Lucy, when you look at Anacha, when you look at Betsy, the 3 primary women of the 30 women who were utilized in these guinea pig surgeries to actually try to help a very valid situation where there was a mixture of the urine that came from the bladder and down the urethra and so on. That was very useful. It was common, during trauma, during rape, especially Black women raped to such an alarming rate. During that, it was a necessary procedure to learn about. But when you have 12, 15 white men around a Black woman sitting on a table, and excuse the language, but doggy style, right? Bend over in such a way and entering her vagina from behind. And if she's not feeling pain, what's the purpose of holding her down? But they justify and say that he was doing a good thing. After he left Alabama and went on to New York, where he becomes the grandfather of
Oh, we seem to have lost
Black.
Oh, there we go. He's back. Sorry.
So
we lost you for a second.
Okay, I'm back. All right. So there's no record of him working on another Black woman. Having said that, you have that history. This is in Alabama. Down the street from Montgomery is Tuskegee. And so we're talking about the mid-1900s. And in my research, I've shown where the that one of Anarch's children, she's from Macon County, where the syphilis study began in 1932. The first 6 months of the syphilis study was actually justifiable in a sense, not as because they were trying to monitor how syphilis is impacting this major syphilis community. It wasn't that they injected or infected the men of the study with syphilis. It's just that there was a high concentration of syphilitic men in that region. The problem was, as it went on for 40 years, up until 1972, even after syphilis was found as a cure for syphilis, even though penicillin was found as a cure for syphilis, they still chose not to use it. So the argument was, when you have such an extended period of time of someone being syphilitic, that penicillin is no longer useful. But what about all of those who contracted syphilis during the time from 1940 and beyond? The United States Public Health Service, under Dr. John Cutler, the Surgeon General, went to Guatemala and affected 1,200 people. They actually injected them with syphilis. So the historical atrocities justify the pause that Black people have against medical treatment. But my problem is, and this is what we want to push a little bit, is that justification, though rational, though fully justified, right? Is it sufficient to restrain ourselves from participating in clinical trials, given how weighty the results will be if we don't? So I think that there's a moral tension there, and there's a scientific tension about how do we be good advocates with integrity to our community, knowing that the disparities exist, the institutional memory exists, and we know that this could be actually helpful. But at the same time, we know that the nasty works that has been done in the past. So that's my comment about that to Dr. Doyle, and what I wanted to offer in terms of the ethical side of this conversation.
Just one quick thing before we go into the ethics about that. Lindsay Webb wanted to know, where can we find Dr. Oliver Rollins' book?
The book is not out yet. It is due in spring of 2021. It'll be under Stanford University Press. The title is Conviction. And I'll talk a little bit more about it whenever my time's up, about the book. Thanks.
Okay, and leading into the ethic considerations of this, one of the attendees asked a really good question. They asked, like, how about in regards to biases and pain? Do doctors often believe Black women can take high levels of pain, even through studies that disapprove this? What should we make of this today?
Is that a question for me?
Oh, that's a question for any of the panelists concerning pain. But I think it would be appropriate for you and Dr. Doyle, because it's pain.
Okay, Dr. Doyle, you could go first.
Sure. So it's, when we study, actually it's gotten to the point where I don't know if we need to continue to study that, Black people are being treated differently in terms of pain management, versus the how do we treat it. It's been studied time after time. There was a meta-analysis that was done. It looked over 20 years of data, and it showed that on average, Black patients are getting close to 0.25% less pain medication. And this is not for some of our invisible illnesses, things that you can't really see. So someone coming in with a migraine or chronic abdominal pain or chronic pelvic pain. These are instances of you break your leg, you have a kidney stone, you're in a sickle cell crisis, you're dying in a hospice with cancer. Even under those circumstances, patients are still not being treated the way that they should be treated. There are a lot of biases that go into this. There have been studies that looked at US medical students and shown that 10 to sometimes 20% of students believe that Black patients have thicker skin, Black patients have less sensitive nerve endings, all of these things. And then we have to kind of teach around or reteach those ideas. So some institutions have instituted implicit bias training, which often is not enough. A 1-hour course in implicit bias training is not enough to undo some of that racialized programming that leads to someone who is Black having a fair access to pain treatment.
Let me add this part. One of the things that will always be an elephant in the room is that Black people are extremely religious in America and elsewhere. We are very religious people. As a matter of fact, I served as a pastor for many years. I trained in that regard. And one of the things that's always been interesting to me is that parishioners will call it pastor before they call it doctor. And they will say they call it pastor, and I have this particular ailment, where do I go and who do I go to? So now the trustworthiness, I think, a little conversation yesterday, the trustworthiness is directly in the hands of the clergy and teachers and so on. There's a particular set, W.B. Du Bois talented 10th, there's a particular sector that is being trusted. We have to find a way to reach people in ministry. I don't care if it's Islamic ministry or Christian ministry or wherever. We need to find a way to reach people in ministry and educate them to educate the people, and let them know that there's a chance that you would have the best access to health care, because you will not be receiving the amount of pain management that you deserve. Often people assume, because the first person is your pastor, the second person is your doctor, people trust what their doctors are saying. And if their doctors are giving faulty information, they tend to go with it simply because my doctor said it. The whole notion of getting a second opinion, that's lost on Black folk. We're struggling to get a first opinion, right? We're struggling to get our people out to particular preventative healthcare maintenance. So the notion of getting a second opinion, that's not where our conversation is yet. So we have to try to find a way to reverse the slave mentality that suggests that we're biologically different to that extent. If we don't, we have the original mass incarceration of slavery. We have the second mass incarceration in terms of slavery by another name, right? Where people were placed back into prisons just because they didn't have a job. We had a third mass incarceration, is the one we typically could call today as mass incarceration, where so many Black folks are in prison. But we have a fourth mass incarceration, and that's where we're imprisoned in our own bodies. Our own bodies have become prisons. Because in terms for children, we become unhealthy in terms of their weight and obesity and so on, because they spend so much time on screens rather than going outside and running and playing and jumping like we may have done when we were younger. So we have to kind of shift the paradigm of how we think about our own healthcare, come up with a manifesto that we can give forth and teach the people that to have high expectations and do not back down from those expectations. Question your doctors. We are often afraid to question people in authority. Question your doctors. And if you don't know what questions to ask, take someone in your family, all these young educators, Black students at HBCUs, take your grandchild and then have them to question the doctors.
I think that's a great point, especially when it comes to, trust with providers. I don't think the trust is there. I don't know that the medical system necessarily deserves that trust. That's something that should be earned. And I think, bringing in, religious providers can be an important aspect. I also think, with Gen Z overall, some people are becoming less religious. So we need both pathways so that we can empower people to really say, here, this is the best way that we think we can manage your pain. Often it becomes an issue of trust, even with COVID-19, with trials for COVID-19. A lot of the trials have not included a lot of Black people. And it's a two-pronged issue. One, are they being offered? Two, are they interested? And are we interested in putting together the resources where they truly feel empowered to make those decisions? And it can be difficult to make that decision, to have that trust within a system that has offered no real atonement, no real reparation, no real acknowledgement of many of the wrongs that have been done.
Thank you very much there, Dr. Doyle. So I'm going to switch tack a little bit, but it was something that was mentioned by Dr. Hodge, which was about mass incarceration. So So Oliver, we know that you have a book you've said that you've got coming out called Conviction. Can you actually tell us about the premise of this book and give us a bit of an idea?
Sure. So, so to kind of get to the point of how I got to this book, I think will help kind of in the explanation. So when I started research for this book when I was doing my PhD, so I went to UCSF, and the whole point of me going there was to think about, violence as a health problem. As you know, it's like a health and science campus. And so they have a sociology department, even though we don't, it's not, I don't think most people know that like it has a sociology and anthropology departments, but the sociology department focuses mostly on medical sociology. And so one of the things that I wanted to focus on was think about how violence is a health problem, right? To kind of reframe it and move it away from the criminal justice problem. So one of the things that that led me to this was even is thinking about like the leading causes of death. And so in the US, if you look at leading causes of death for African-American males between the ages of 16 or 15, I should say, to 35. Now, this is when I first started doing this research, around 2009, 2010. The leading cause of death for African-Americans in that age group was homicide. If you go and look right now, the leading cause of death for African-Americans in the US, African-Americans in that age group is homicide, right? So the question that I had was, why is this only framed through a criminal justice lens, right? And so that kind of led me into thinking about like crime and its relationship with race and doing violence prevention work. However, when I got to UCSF, one of the things that they also do is around science and technology studies, right? So I had a lot of mentors and folks who were really, really thinking about the relationship between genetics and race, and particularly the ethics and social consequences of both kind of reinforcing race at this biological level, like coming back to this question, is race biological, and using kind of genetic technologies to kind of make this point. And so a lot of them were pushing back against this. What I wanted to do in the book or in the dissertation at the time was to think about how neurosciences actually deal with race, right? So I wanted to kind of do a very similar thing that they were doing of thinking about how genetics are dealing with race and how the neurosciences deal with race. And so I picked, to think about violence because in my head, I'm like, okay, how do you not deal with race if you're going to study violence, right? Particularly within the US. There's really no way around thinking about the impacts of race if you're going to think about how or why someone will behave violently, right? So that was kind of how I got into the book. What the book ended up being, though, is really a question about how you produce this research in the first place. And really, I guess a key point of it is, or my key argument is the fact that like this science, or at least the ways in which this, the thinking around kind of the neurobiology of violence does not do a good job of dealing with inequality. In fact, inequality doesn't really fit in that model, right? So one of the first things of course, we would look at is like, okay, well, are these scientists, how are they thinking about race, right? Or are they making racist claims, right? Because the first point we usually think is like, well, they're probably using this science to then make some racist claim about Black men or Latino men being, innately violent because of their brains. Well, that's not actually what's happening within the science, although there's definitely a history of that, right? And so there's a reason why you start with those types of questions, because there is a history to that. And that history is informing the science today, right? So really what I found is that so much of that history is also informing them not to actually want to talk about race at all, right? So much of that science is actually devoid of any racial conversation, right? In fact, it would almost seem as if this is a race neutral science, right? That we don't necessarily need to talk about race because, and for good and bad reasons, right? That they're doing it. One, to kind of protect themselves because they don't want to be necessarily called racist for any kind of work they do, right? So if they find racial differences, they don't actually want to report them. But the other part of that is just a question of like whether or not they can even capture what that means, what race means. And beyond what race means, I asked the question of whether or not you can capture the effects of race. Because it's not, I'm less concerned about whether or not you can capture racial identity, because racial identity does not necessarily tell us the things that we want to know about inequality in a way. What we want to know is how you're treated because of racial identity, right? And so the ways in which you're treated in society, the effects of race, or what we would say racism, right? How do you actually capture that, right? And so I asked a question to them, right? Because essentially what they told me was, well, it's very important and they want to be able to capture it, but it's too complex for the model right now, right? This was essentially kind of what I was told. This is just a very complex for the model right now. Now, I will say there are some neuroscientists, I think, that are trying to work on that now, and I still have some critiques of like these things that they're trying to do to capture racism. But for the most part, most people are saying it's more or less too complex. But then that begs a question: if it's too complex, and how in the world could you tell someone like me, you know, who definitely are going to be impacted in the ways in which racism works in society, my risk for being violent in the future, or my child's risk for being violent in the future, if you can't actually deal with the ways in which race structures how we think about violence within society, right? So this is not a question of whether or not you can measure race. It's not a question of whether or not you have Black people within your study. It's a question of whether or not you can actually deal with the effects of race and how those systemic impacts, right, structure our society. And they structure the ways, not simply how we build our society, but actually how people are going to treat us and our life chances. So I asked the question, you know, or I say that there's a failure to see racial lives, right? There's a failure to see the ways in which race actually impacts people's lives beyond just their identity, right? Beyond just capturing their identity. And so, and honestly, that's only a chapter within the book, because the larger book is really building on this notion around inequality and building on this notion just around kind of this notion of the social, right? Because so much of science today, part of this kind of larger conversation is that we, you know, that moving beyond kind of a more deterministic kind of science and taking serious the impacts of the social means that I'm going to measure some form of the social in some kind of way, whatever that thing is, right? But often that's a very limited thing, right? The social comes down to things like, well, I measured, you know, child maltreatment. Okay, well, that's one measure of the social, but that does not count as all social things, right? And so that won't necessarily help you when we start to think about things like risk, right? And the bigger problem with this science is, or the bigger question and problem, I guess, is that one is already moving into the courts, right? So we're seeing more and more neuroscience literature kind of get into the courts. The courts are being much more open to thinking about the ways in which neuroscience can or cannot impact particularly criminal trials. Although it comes in at different stages in criminal trials, usually much later, kind of, you know, once someone is already found guilty, right? But the other problem with that is the other use of this is to think about prediction, right? And so I think that's where it becomes very, very questionable around, like, you know, whether or not someone's going to, reoffend, or whether or not they will offend in the future. So I start the book and end the book with a question around, you know, whether or not, you know, if we know that a young child is neurobiologically risky to be violent in the future, what do we do as a society, right? What are you asking us to do as a science, right? What exactly do you want us to do in that sense, right? Because none of these things actually deal necessarily with these structural impacts, right? More than thinking about it at the individual level. And so that's the other kind of critique, is to think about, why are we kind of focusing on individual level solutions to things that we know are structural level problems?
Okay, thank you for that. That was very insightful. Building a piggyback on that, I was wondering, at least from the audience, we have another really good question. Could a lack of neural coding contribute to racism? Like, if you haven't worked with a Black scientist, or you haven't encoded working especially with a Black individual in your brain, like, what would be the default behavioral output in the scenario based on implicit biases and potentially results in microaggressions?
So that's a very interesting question. And I think, so that goes to kind of the second project that I'm thinking about with, like, the neuroscientists who study implicit bias. So, I mean, it's an interesting question to ask in the first place around whether or not one has, you know, I think it's interesting to think about whether or not we're in a way in which we're so separated from race that we don't understand another race. I don't necessarily buy that in some ways, that we're just that separate that we don't understand people's race. I don't think I think there's too much ways in which we communicate and we understand race in a way that you are in contact, and we're constantly in contact with other types of races and understandings, right? So I don't think that part of it is necessarily the case. And also, even thinking about it at a neurobiological level, we have to kind of ask some questions like, what is that science actually saying? So, in part of that science, so right now, what that science is usually kind of focused on is two things. One is a relationship between the ways in which we recognize race, so racial recognition. And the second part of that is the ways in which we manage or not bias. Our bias is based on that. So the first part is usually based on how we actually recognize someone and whether or not we recognize the other. And it's built on, you know, a larger kind of base of facial recognition and things like that, and identity recognition that comes out of the neurosciences that actually, so it's built on kind of this solid science, right? The question becomes, though, can we simply, like, boil this down to, like, two things? Can we simply boil things down around, like, racism to things like just managing bias and implicit bias, right? Because part of my argument, right, is not simply that we're, in the ways in which we think about science. I think that the neuroscientist has a very normative valence, right? Because some of the questions that we're asking, we're not actually really digging into the assumptions that we have about those questions in the first place, right? That assumption that we believe that people are so separate that they just had no contact with Black people, therefore they act in that way. That's not really why we act in racist ways. It's because our society in itself is built on these things in very normative ways, right? The things we don't question, right? If we go back to the book that I'll go back to my book, one of the things I ask is that, so one of the measures they use to think about violence is contact with the police, arrest records, right? But what's not questioned is how arrest records themselves are highly racialized. They're highly classed, highly gendered, right? Those things then get built into our science, they get built into our assumptions, and then they get built into the ways in which we're making, when we try to make sense of what those things mean, right? So the question itself, I think sometimes we have to back up and ask, why do we want to know whether or not our brains are neurobiologically wired different to think about this in a way? Because I don't think that's the case, right? I don't think that it is a simply like rewiring of brains in that way, right? I do think there's probably some validity to thinking about how implicit bias works, right? At that neurobiological level, but I don't think it's as simple as saying, can we rewire our brains and then therefore people will act better racially? Because these things are not necessarily things that people are doing. It's not simply that they're doing them like not on purpose or not. It's that they're doing things that are normal. They're doing things within our society that we both treasure, that we both reward, right? In ways that don't necessarily look like the old racist ways that you know we had back in the Jim Crow era, right? But they do the same type of work.
Perfect answer. On that, and on the back of quite a few things that you've said, I'm actually going to bring in both Jordan and Tony. So probably going to go straight to Jordan first, but you mentioned, Dr. Oliver Rollins mentioned a little bit about prediction. And I know that you've actually spoken quite at length and on your YouTube channel as well about the potential of AI to be racist. And we know that AI itself cannot be racist, but the potential of those who actually code it can themselves, or who design it, can put their own biases into that discussion. So for me, can you really just touch on what you meant by that video and those sorts of things?
Yeah, so a more, I guess, precise way of titling that video, or titling any video that starts to get into AI and race, is that AI is one of the many tools that can be used to propagate, assist in developing and maintaining systems that then perpetuate racism. And so there's a lot of different ways that this can happen throughout the entire pipeline. You can look at data sets in terms of data sets historically not representing the populations that they're going to be used on. And so you can look to that for a potential correction. You can also look at the models themselves. So studies have shown that neural networks tend to amplify existing biases in their data sets. And so even if you have a data set that has minimal bias, or you think that you've solved the problem on the data end, you may not have actually solved the problem at all. And I think the bigger issue that I tend to see, and I think Dr. Rollins actually mentioned this a little bit earlier, is just not necessarily asking the right questions, or thinking that you're asking the right question and you're not considering the assumptions that are behind those questions and the kind of secondhand effects of the systems that you're trying to develop. So a great example of this is actually a Nature, I think it was Nature paper from last year, that looked at an algorithm that was being used in clinical settings to determine whether or not patients got a personalized treatment plan if they were significantly sicker than other patients. And the paper found that essentially equally sick Black and white patients were equally sick Black and white patients. The Black patient was a lot less likely to get that personalized treatment than the white patient was. And there were a lot of different variables that went into how that decision was made. But one of the variables that they used was how much a patient spends on healthcare in a year. And I think the assumption, which at surface level makes sense, is that patients who spend more money on their healthcare are sicker, because you're spending a lot more money on healthcare. So you must need to do that for some reason. And what they didn't factor in is that Black patients just tend to spend less money on healthcare. And that's for, a lot of the reasons that I think other panelists have already brought up in terms of how the Black community engages with medical systems. But it results in the data that's being used to train this model shows that, Black people just spend less money on healthcare. And so when you get to predicting whether or not someone should get that better treatment, you end up saying, well, they're not spending that much money on healthcare, so maybe not. Maybe they're not as sick. Maybe they don't need it as much. And so I think it's instances like that where, people are asking one question and they're not necessarily looking into the implications of that question or the implications of the data. That makes it harder. And it's not always an easy fix. In fact, it's very rarely an easy fix anyway, because there are some cases where, explicitly considering race in your algorithm may be like illegal. In the US, that's an issue for things like credit algorithms, financial algorithms. If you're trying to, correct a potential bias in terms of giving someone a credit score or approving them for a loan or something like that, it's illegal in the US to explicitly consider gender and race in that decision. And that was originally instituted because there used to be, in person, you'd go to the bank and you'd ask for a loan. And if you were a woman, you might need to have your husband signed off, or if you were a person of color, you probably wouldn't get the loan at all. And that law was created to fix that problem, but in doing so, we still have this data set that's super biased. So yeah, there's definitely a lot of ways that it factors in at kind of every level of the model in terms of development, in terms of the people that you have building your models. There are people who, depending on your background, you may not know to ask the question in the first place. And so that's one of the many reasons why having diverse teams is super important, because you have people asking questions that you may not have thought of and considering the models that you're trying to build in ways that you haven't considered. And then I think the other thing is just community buy-in, and this is always a little bit of a nebulous topic, because in theory, when you're developing a system, you should be asking the people who it will be used on what they think of it, and whether or not, what kind of trade-offs they're comfortable with and things like that. And in most cases, it's actually the people in power in the system who get asked those questions and who get to make those decisions. And that often ends up with, you might have like a facial recognition algorithm for surveillance, where the police, who are the consumer in that case, may want something with, you catch all the criminals, but you might have a lot of false positives, and that's okay for them. But for the community, you might want something that, like, you catch most of the criminals, but also the false positive rate's pretty low, so you don't have to worry about being misidentified as someone who committed a crime that they didn't commit. And so that community conversation doesn't always happen. It rarely happens. But at the same time, when people talk about building like more diverse data sets, you end up with like people scraping images from Facebook without people's permission and stuff like that. And so I think that there's a fine line between like community engagement and community abuse in that sense, in terms of fixing as much as you can fix bias in AI, because it all comes down to your definition of what's fair. And that really depends on who has the power in the development process and the production process and the final deployment process. And, the definition of fair has varied a lot over the years. And I think in artificial intelligence, we're starting to consider a definition of fairness that looks at how algorithms shift power. And I think that that's a really interesting and probably, hopefully, a more effective approach than looking at, does algorithm A result in equal outcomes for population A and population B? Because there may be aspects that you just aren't considering in that calculus.
Excuse me quickly, if I could, I want to conflate something that De-Shaine said and something that Jordan said. I think it raises an important ethical question, and that is, De-Shaine said that the technology and the science is not in and of itself racist, correct? The science is not racist, the technology is not racist. If you have a prosthetic, the prosthesis isn't a racist thing. But doing work with neuroscience and some wonderful people at Case Western Reserve University and otherwise in the Society of Neuroscience, it become very interesting to note, Jordan, that the scientists are in their laboratory and they're focusing on creating some technology, and they're fixated on that. They're oblivious often to what the dynamics are in the real world situation. Yeah. So, as in the case of a prosthetic arm that has sensation, that could pick up a grape, and the person feels it or holds his wife's hand and feels it, hold his baby's hand and feel it. If clinical trials continue to have such a massive disparity with below 5% of Blacks involved in clinical trials and 95%, then when these opportunities come, we're already behind, right? Because the first person will get such technology is the military. And then after that, the gamers. And so we're already behind. So it puts us at a tremendous disadvantage, not because of a racist thinking in the scientists, but in the way the system is structured. It disallows access, opportunity for those who need to be in the conversation to be included in the conversation. And therefore, the masses of us who are out here in the conversation need to really start a loud trumpet to let people know, because a major part, one word that I just want to toss into the conversation is the notion of empathy. Empathy is something that could create understanding and level the playing field. Empathy aligned with care puts wheels on care to make care happen.
Okay, great answer and great follow-up. I'm just gonna piggyback a little bit off of what it was Jordan saying, with AI, and directly go into the recent announcement with NSF. So anonymous attendee has stated that the NSF GRFP, which is the Graduate Research Fellowship Program, has recently shared they will be prioritizing AI in computational research. So could a panelist speak to this choice? In particular, I was kind of wondering like what Tony's thoughts about this is, because he works directly in AI at IBM. So I was particularly wondering, like, what do you personally believe, like, what that means? And like, could you speak about this choice in regards to ethical dilemmas of AI and surveillance? And how would this prioritization affect early career Black scientists and engineers?
Sure, well, definitely. Thank you for having me. Definitely the biases and prejudices are of concern. As a technologist, we need to make sure that that AI and machine learning technologies actually deal with those, right? Deal with those biases and prejudices, because you don't want those in AI technologies, right? So because what AI is doing is infusing, we're infusing AI into our current applications, right? Today and new applications to make things like accurate predictions and automated decisions and processes. And those are very two key things, right? Decision making and predicting, right? We're building AI that can combine different forms of knowledge, unpack casual relationships, and learn new things on their own, right? So this is where you get into very intelligent and not to mention difficult algorithms. And you want these algorithms to be all inclusive, right? You do not want algorithms, and we've mentioned this before earlier on this call, you don't want algorithms to have biases and prejudices. We already have humans for that, right? So we're talking about complex human reasoning, right? And Jordan had mentioned this about things like surveillance systems, right? If you had for example, a surveillance system in a financial institution, and the team chose to, who did the training for it, simply showed it 5,000 male faces of one complexion. Well, that's not going to be a very successful surveillance system, right? I don't know of anyone who's going to benefit from a surveillance system that's been trained like that, right? You're not going to get the results that you desire. So, all inclusive, meaning you need to have a diverse team, right, to actually feed. And this is what Dr. Hodge was sort of getting into. You need the diversity of a team with the background and the various and the ethics to actually feed these algorithms. So as these algorithms grow and learn on their own, they're dealing with the biases, they're dealing with the prejudices, and they're actually handling them in a way where they don't cloud the judgment, and they're eliminating, as Jordan mentioned, the number of false positives, because you want as less of those as possible. Now, Tia, I don't know if I answered the question exactly. So if I didn't, can you point out where I didn't, and then I'll speak on that again.
From my knowledge, you did understand that. I can't remember exactly what the question was because one of the moderators said it was answered. Well, here it is. Oh, okay. So how would this prioritization, how would the NSF prioritization of AI research affect early career Black scientists and engineers?
Well, you want to set the precedent, right? You want to start off with the diversity of the team who's actually working on the AI or machine learning program. That's where it begins. I mean, we all talk about AI and machine learning, these algorithms taking on a life of their own, which can be sort of scary for some, but taking on a life of their own and learning new things and making decisions on their own. But the very first algorithm is going to begin with a team. The team needs to have a wide base of as many backgrounds as they possibly can. You're right. You want as many balance checks as possible going into the initial algorithm, because you have to have a clean, sufficient foundation for the algorithm to actually be created. So, in essence, exactly to this question, there's room for everybody. These scientists, these young scientists, people who are interested in this, to actually get involved and engaged early to bring these very diverse thought sets, these backgrounds, and to help this all-inclusive approach. Because as a technologist, we do deal with these things, and we do understand that there's a problem. So pretty much we want everybody involved and engaged.
Perfect. I'm just going to piggyback off that, and this is a final question for Dr. Doyle, because I know that you have to go into the clinic. I'm just quickly going to ask, so we've talked about technologies and the development of them, but we do see a lot of cases, even just going back a bit further in terms of medicine, where certain technologies themselves can have a bit of a racist element to them, even regards to the I think it's GFR, so the glomerular filtration rate. So is there anything in neurology specifically, a technology or a practice that you would say would discriminate or be a bit problematic with regards to Black people?
Well, there are probably several things that come to mind. We look at like opioid risk tool stratifications that we use to see if someone is appropriate for chronic opioid therapy. And a lot of those things look at, mental health diagnoses. It looks at a prior history of trauma, especially before the age of 18. So that could definitely lend itself to bias. There are some practices, not my own, but they'll look through the local criminal records when a patient comes in to see if they're a candidate for opiates, which obviously for me, if I look through someone's record and I see, okay, there's some run-ins there, I don't necessarily think much one way or the other, depending on your environment. The amount of police interaction that you have is just in relation to the neighborhood that you grew up in and the color of your skin. And so that interplay between access to care and bias, it comes up again and again. And we're taking a closer look at a lot of those algorithms that we're using that often might bias against Black patients getting transplants, getting cancer care, getting access to pain management. And it's a diffuse issue. If you look at the state of Maryland today, they just legally said today that law enforcement can no longer say that they smelled marijuana and then go ahead and search you or arrest you. I mean, that has implications in, the school to prison pipeline. It has implications for patients who use medical cannabis for pain. So like Tony was saying, we have to be in the room when these decisions are made. Who's in the room when all of these things get signed? And in addition to diversity, there has to be inclusion. So you have to be there and you have to feel comfortable enough that someone's going to listen to you and not admonish you or judge you. You're not going to be sidelined as someone who just always wants to talk about race and, oh, here they go again. They're bringing up race. So you have to be truly included in those conversations. conversations. You have to feel empowered in those conversations. And that goes to a whole change in the culture of whatever your society you're looking at, NSF and otherwise. If you can have a lot of us in the room, but if we don't feel that our contributions will matter, or that our voices will matter and be heard, then it's all a waste. And honestly, it's a stress and a burden and a trauma on those people that you've decided to include or possibly tokenize. So I think the more transparency, the better. And I definitely think, there are algorithms, there are practices that introduce bias into pain management.
Thank you for that. I just wanted to say for everyone here in the chat, just a huge thank you to Dr. Doyle, because she has to go back to the clinic right now. So thank you very much. If anyone can put their thanks in the comments.
Thank you.
Well, yeah, we're going to continue. And I'm actually going to go back into the AI sort of space. So again, Jordan and Tony, be ready. But specifically, I know for Jordan, you actually do quite a lot on the side of science policy. And we're talking about the advocacy and having diversity, etc., in these spaces. So can you tell us a bit about the science policy that you do?
Yeah, so the External Affairs Board for the MIT Grad Student Council, at least, focuses on a lot of different topics. I think the broad topics that we tend to focus on would probably be science funding and immigration, because those are the two that kind of come up all the time, especially recently. But in terms of, I guess, policy work within the Black community, I think, so MIT doesn't do a ton of that. There also aren't a ton of Black people in MIT. So those two things are probably related. I can actually speak a little bit to the NSF stuff too, because I have an NSF, and specifically looking at the impact on, I guess, early career research for Black students. And my intuition on that topic is actually that it probably won't impact Black students that much, not because it will, push the needle in any particular direction when it comes to the research that's being funded. I mean, obviously it will, but more so because the NSF, while I think it ideally is a way of funding minority students, does not historically do that. It historically tends to fund R1 institutions, places like Ivy League schools, places like MIT. And so I think that the shift in focus is certainly something to be noted, and something to, I think, challenge the logic behind. And why is this decision being made now? Why is it being made when they're also cutting the number of awards by, I believe, 20% this year? And how does that affect the research that we see come out of academia, especially coming out of institutions like MIT, Harvard, Stanford, which already tend to have a pretty big focus on these areas of research. But in terms of its impact on Black students, I think that because the NSF primarily serves high-ranking institutions, it will continue to do that. In terms of, I guess, in terms of science policy work, I think that there's a lot of, or advocacy work, I think that there's a lot of work to be done, I guess, within scientific communities. I think that within the field of machine learning, AI, whatever you want to call it, there's a lot of different words for different kinds of statistics. But I think that one of the great things, I think somebody actually asked in the chat, that grad students can do is just continue to push the issue. There's certainly pushback from people who have been in the community for much longer. And I think that, it's going to take that internal advocacy from your early career researchers who are newer to the field and who are starting to learn about these issues, to change the field overall, because eventually we're going to be, the senior researchers in the field. And so if we keep pushing for it, I think that slowly the fields themselves can change in really good ways. In terms of non-institutional or non-kind of scientific research organization advocacy, I think that a lot of the work that is often overlooked, but is probably more impactful on a day-to-day level, is local advocacy. I think that everyone wants to march into Congress and demand that policies be changed to, you know, in whatever way, make your life better. And I think that at the local level, you're a lot more likely to have substantial change because you are a bigger, essentially, voting population of that voting group. And I think that you're a lot more likely to see changes that can then be propagated further up into the system. So you can have, you can elect people at the local level who support causes and issues that you believe in. You can then, support them while they're in their terms. You can advocate for them as they move further up through the political ladder. And I think that definitely the value of local advocacy for policy is often, I think, overlooked. State, federal, also super important. But I think that it's often the first place that people look when it comes to doing advocacy work, and reforming your community is often a good way to get the ball moving higher up.
Thank you for that. Go ahead. Does anybody else want to comment?
Yes. I was wondering if it was okay I could respond to a question that popped up that one in a Q&A. I think someone misunderstood what I said, and the person said that that I said to trust the doctors even if the doctors are wrong. I didn't say that. I said that we are justified in not trusting doctors because of the historical and implicit racism. So we're justified. Therefore, we should raise questions, a lot more questions, but don't just trust the doctor. That's the problem. The syphilis study was about trusting the United States Public Health Service to do right, and they did wrong. I trust my barber to give me a great haircut. I do not trust my barber to fix my car. So trusting and trustworthiness has to do with competency in the field. So if you think if a doctor is wrong, you shouldn't be going to the doctor anyway, right? But if you think that a doctor is wrong, I said raise questions or take someone with you who raise questions. My mother's 88. My sister is the primary care. My sister would call me from the doctor's office to ask me about additional questions to ask. We have, consistent with this conversation in terms of neuro, is the notion of Alzheimer's. I mean, listen, we are in a mess with Alzheimer's. If you're over 80, 50% over 80 are going to have Alzheimer's. And among the 50%, a double of that number will be women of color. And so we don't have the time to play around with our healthcare. We must place our trust in those who are trustworthy. So I hope that it makes it absolutely clear that I'm not saying just trust folk. I'm saying, like Dr. Danielle Doyle was saying a moment ago, that pain management has long been a major disparity from in slavery, that Black people could tolerate more pain. That's just stupid, absurd, and implicitly racist. To suggest that what you're saying then is that back to 3/5 human, we're less than human, so we can take more pain than anybody else. That's just wickedness, is nefarious, is wicked, and so on. So therefore, I'm not saying at all to trust a bad doctor. I'm saying leave that bad doctor to do what he or she's going to do. But I'm saying raise questions. Do not trust just about anybody with your healthcare. And finally, when it comes to mental health, that's another hotbed in our community. Growing up, I'm from the Virgin Islands. You all probably heard my sweet accent already, right? But I'm growing up in the Virgin Islands. Everybody, and I'm sure where were you from? Over Chicago, right, Tony? Everybody had a crazy dude in the neighborhood. You said, that's just Pete. He crazy. But yeah, and they became part of the urban legend and the folklore. They're human beings, and they're part of our community, part of our family, and they were suffering mental health illness back then, and they're suffering it now. So back to what Sister Jordan was saying there, is that we have a responsibility to build community, and when we're at the table, be courageous enough to say what we have to say, regardless of the consequences. because a whole lot of people are depending on us to speak on their behalf because they simply they lack access to the table. So I hope I was clearer now than I was the last time.
Okay, excellent answer. Actually kind of segues into another forgot his name, John Hernandez. He says that you speak about how Black men and women trust their doctors. Sometimes when the perspective is wrong or right. He says that he finds it very stressful talking to his loved ones about mental health. And he's realized that his family isn't changing just from his perspective. So does anybody on the panel have strategies to suggest for starting continuing mental health conversations? Thank you.
Well, okay, so no one is going. This started when I was. This was the end of what I said a moment ago, and yeah. Oliver, you might be right up in there. But the first thing is that to take the conversation seriously. Suicide among young Black men is on the rise. Now, the oddity is historically, Black folk have been trying to live. You know, Blacks committing suicide. Wait, why should I do that when somebody else want to kill me? But they're trying to live. So it's a total paradox to see Black people committing suicide. And for those of you who are still in the PhD program, there's a rising number of Blacks in PhD programs who are committing suicide, in part because the stress is so high and what you're up against is so tough. But I just want to encourage you to push forward. But anyway, when you as John Lewis said, when you see something, say something. In other words, take your family members. Tom Joyner pushed this. Take them to the doctor. They need help. Mental illness is an illness like any other kind. It's just that you don't see it right in front of you. You know, for somebody get their arm amputated, you can see that. But a person with mental illness, oh, they're just so crazy. No, we got to be more than colloquial about mental illness.
Okay, great answer. So with that, continuing on, do you believe, Dominique asks, in your opinion, Dr. Rollins, does colorism play a role in contributing to neuroracism and implicit biases?
Oh, was the question colorism?
Yes.
Well, I mean, even I think in larger society, I think we think that colorism definitely impacts, right? The ways in which race operates within our society. So having a darker colorism and the idea of like those of darker complexion are actually end up being treated harsher within society, or actually, or you know, so when we think about anti-Black racism or anything like that, like the idea that there is kind of this spectrum in the ways in which we think about race, and that people, for various reasons, for aesthetics, for all of these different reasons, for access, for, you know, all the different reasons of why certain people will get different types of privileges within society will impact in the ways in which we think about how inequality works. So yes, and the thing about that, so I think that question is good because part of the question about asking anything about neuroscience or genetics, right, has to start with how you're framing that question within society in the first place. So yes, if we're thinking about the ways in which these things are going to impact society in the first place, right? So yes, then of course, we can think about the ways in which that will play out in racism. Whether or not you can find a neurobiological pathway, I think is a whole different type of question. And whether or not it makes sense to think about this in a neurobiological pathway is a different type of question. But the question around colorism, yes. I also want to kind of like just comment on a few things like before that kind of popped up that made me think about some things. And one of them was that part of this question about race, right, and race in science, right, and how the production of science can reproduce, let's say, racist ideas. I think we also have to think about not just the ways in which someone can have a racist idea and want to reproduce it within their science, but I kind of asked the question, what happens when these racist ideas are reproduced through a very normative lens, right? They're reproduced through the ways in which the everyday ways in which we do science, the everyday ways in which we produce social science, any kind of knowledge, right? That's what I mean by these kind of, this is not talking about our implicit biases. These are talking about these normative ideas that we have about people within society, that we have about society as itself, and then how it gets reproduced. So even the idea that like scientists are going to go into their lab and they don't necessarily think about the social problems. Well, I don't actually buy that, because part of what they're doing with their science, part of what we're doing with our research is to address social problems, right? Part of the idea of thinking about a better way to do AI, right, particularly with crime, is because, hey, we know that there's a problem with the ways in which crime and race play out, in the ways in which Black men, Latino men are highly profiled, right? So what if we move to something like AI, where we don't have to worry about race, quote unquote, right? That we can police places and not people, right? But what we find is that even when you're policing places, even when you're thinking about it in that way, it's reproducing the same type of system that we already had. Why? Because many of these risk factors that we talk about with crime were already highly racialized, right? Someone asked me when I first started the project around neuroscience and implicit bias, and this was actually even before the murder of Breonna Taylor and the kind of breakouts that we're having right now. This was, you know, some years before that. We asked the question of whether or not it would fix police bias, right? And the problem that I had with that was, I was like, well, of course not, right? In fact, what we will see is that the neuroscience will work, right? We can probably figure out who has implicit biases using this, using a neuroscience technology, or even just using the IAT test, right? We can figure out who those people are, right? And we could potentially, let's say, get them off the force. But will our force then, or will these police force then at some point in time be anti-racist? Absolutely not, right? Because if we can still say that the ways in which we're going to police is using stop and frisk, it doesn't matter what the police officers look like, right? Because that means I can stop any Black person, I can stop any person who looks suspicious, right? And that's built into the system. That's an institutional thing. That's not an individual thing within the brain, right? So even moving them out of that does not necessarily mean that you're going to have this kind of anti-racist society, right? And that's the kind of larger question I asked about science, right? What does an anti-racist science look like? Not a race-neutral science, not a colorblind science, right? But an anti-racist science, right? How do we build that, right? And so part of that question too, if we come back to this example around crime, is that what's actually being reproduced sometime is the normative ways in which we already think about crime, right? Or the normative ways in which we think about cognition, the normative ways in which we think about, health, right? And all those things many times already believe that Black people feel more pain, right? Or don't feel pain, I'm sorry. Or already believe that Black people are sicker or they're more criminal, right? And it's not necessarily a belief that's coming out, I think, explicitly, right? It's just the ways in which we are already doing society. That's what I mean by questioning the questions that we have in the first place, right? Or the assumptions that we have in the first place. Like, how do we actually dig into that part? I think is a much more complicated question than looking for racist scientists or racist doctors, right? Or avoiding racist doctors, right? That's a much harder kind of thing to do, but that's exactly what's on the table, and that's exactly what we have to do.
Okay, thank you for that. Great, De-Shaine.
Yeah. So yeah, I'm actually going to go off of that, but go straight to Tony just for a bit of a quicker answer. But so with regards to AI, and especially with IBM, and going a little off of what Dr. Rollins has just said, are there any checks and balances in place, or anything that really mediates such a corporation when they want to do something potentially for profit that may have a bias?
Sure. Well, IBM having 300 and so thousand employees over the entire globe, we have an employee base and a geolocation that'll allow us to have an all-inclusive type of approach when we talk about creating applications, doing clinical trials, creating AI systems for financial institutions, whatever your industry is, right? Whatever the subject is, we have that. We have the footprint to actually have a very as much of an unbiased and non-prejudiced approach as you possibly can. And that a couple of key things is not necessarily unique or specific to IBM, but a couple of key things is that you want that as much of a diverse data set, as Jordan had mentioned, in addition to the diversity within the research team itself that's creating these algorithms, that are building these applications, that are running the AI and machine learning programs themselves. So, and that in itself is an opportunity for early career professionals, in addition to the PhD students or the graduate students at the university. So I wanted to make sure that that's clear, that that's a great opportunity, because I can guarantee you the 75-year-old research scientist who's working on an AI application today is looking at things a lot differently than the PhD student sitting in the class today, right? And if we can get them to work together and get on the same page, we're talking about different perspectives, different thought processes, different views, and that's really what you want, feeding these algorithms as you're building these applications. And that's an opportunity for the early career professionals of today.
Thank you for that.
Thank you.
The current time is 1:52, so we have about 8 minutes left on our panel, and we're gonna go ahead and ask if you guys have any books or anything else or any socials that you want to share one last time. And then this conversation will be continued later on Twitter as well. So don't forget to continue using the hashtag NeuroRacism in your tweets. We'll continue to ask panelists, or not panelists, but audience members if they can continue to ask their questions there. And then one last question before we head out. Besides telling us if you have any books or bodies of work where we can find them at, but one more thing is, what do you think personally drives people's desires to find neurobiological explanations for racism?
I can jump in on that first. That last question around desire to look for like a neurobiological mechanism of racism, I think is a larger just desire to answer questions, thinking about this through a very individual lens, right? And so one of the things I tell my students all the time, right, or one of the quotes I use all the time in my class is actually from Michelle Alexander's book, The New Jim Crow. And beyond the stuff she says about New Jim Crow, which is very salient, like one of the questions, or one of the statements she makes is that there's a profound misunderstanding of the ways in which racism or inequality works, right? And I think that's so true, right? That we have a misunderstanding about the ways in which systemic inequality actually get reproduced. Like we hear this term systemic racism all the time now, right? In these last few months, this has come up in a national conversation in a way that's actually really, I mean, we should be proud that we're talking about it in that way, but there's also ways in which I think that just is becoming a buzzword that we're not necessarily thinking about what that actually means, right? And usually the reason why we think about that is because we still have an understanding that racism is a very individualized thing, right? That someone is mistreating one other person and therefore that is racist. Not that it's a very systemic thing, right? One of the examples I use in the classroom is just to think about within the US, right? How racism gets reproduced through our educational system. And I'm not talking about racist teachers. I asked the question of how do we fund schools in the first place, right? We fund through property taxes, right? Well, funding through property taxes means that since we already have residentially segregated communities, right? And residentially segregated communities means that we have a different type of economic situation within these communities, right? That means that the schools are gonna look different, right? There's nothing inherently wrong with doing like funding schools in that way, but it is inherently wrong if it's constantly gonna just reproduce the inequalities that we already have. That is a normative thing, right? That is not, you can't point out the racist there really, right? That is something that's built into our system, right? And so that is a much harder question to deal with. And I think historically, you know, we can go back, you know, layers and layers of like sociologists and anthropologists and scientists who have looked at the fact that like, yeah, we usually shift attention away from those harder structural questions to something much more individual. And because genetics or neuroscience, you know, neuroscience is the kind of knowledge of the day, right? It is the ways in which we think that is going to be the most profound understanding that we're going to give. It actually makes a lot of sense that we move to this. Like it makes actually complete sense that people are trying to figure this out using genes or using neuroscience, but it doesn't mean it answers those questions, right? And actually, it may actually compound those questions even more because it moves so much more attention to individual level understanding.
Thank you.
Mm-hmm.
Anyone else like to answer that question? Nobody at all?
Well, if I may, sorry, I'm back. So I think the question was, what drives some people's desires to find neurobiological explanations for racism? And I think, you know, I heard it described that, you know, we have a hard time distinguishing between true history and cultural memory. And so with everything going on with this reckoning going on in terms of racial justice, there's going to be guilt, there's going to be shame, there's going to be denial of all of those things that have happened in the past. There's going to have to be self-recognition of our own participation. Even all of us participate because we're participating in a system that helps feed us, clothe us, keep our families safe. So we're all participating in a system that uses systemic racism. And like I said before, it's a feature, it's not a bug. Even if you got rid of every racist and you still have a system that is racist, there will still be racism. So I think once we can, have people kind of deeply acknowledge their own participation, then it's easy to, after that, you can dissociate a little bit and we can start to get some work done once we get past some of those ideas.
Thank you.
I think fundamentally is a character issue that white supremacy is far worse than we ever thought it was. And in the book, The Unthinkable Earth, he begins the sentence by saying, it's worse, it's much worse than we ever thought. White supremacy has invaded every aspect of every system in our culture. And when you think about, was it Freddie Gray? The police officers involved in his death, most of them were Black. So, like Dr. Doris just said, you remove all of the humans, all of the put color blindness, and you still have a problem because of system. And the agents who work for the system have a mentality of white supremacist ideology. So therefore, we are already in the back. There had never been a system to incorporate Black people after slavery into the community, probably because slavery never ended. Bob Marley said, I have no chains around my feet, but I'm not free. Just because I'm not on the plantation, that doesn't mean I'm psychologically free. And we see this kind of momentum on a daily basis. So, to your question, when I say it's based upon character, I'm coming from a virtue ethical kind of point of view that suggests that each person needs to work on their character. We are so afraid of our neighbors, or gay neighbors, or lesbian neighbors, or Black neighbors, white neighbors, whatever, that we don't even talk to our neighbors. We don't know who our neighbors are, and that's a terrifying feature. But we enjoy perpetuating the American hypocrisy that we're the land of the home of the brave and land of the free. That's a perpetuation of nonsense. The bottom line is, too many of us are stuck, absolutely stuck on the bottom. And if somebody doesn't have the courage to go down and retrieve them, then they will always be there. So in terms of my last word, I do have I have a book called God for Silent Tears, Women of the Bible, Healing Women of the Day, of today. I have another book called In the Midst of My Tears. Those are all available on Amazon. My dissertation has been downloaded over 2,000 times worldwide. And so to get it is easy to download. It's just type in David, Hodge, and Jesus, because it's actually Jesus as a moral philosopher. So those are my past writings, and my present work include, Dr. Doyle, you would love this, a absolute rejection of what J. Marion Sims and his followers would call a moral dilemma. It was no moral dilemma. It was wrong. And so therefore I'm writing, so I'm taking into consideration all of those who are putting energy behind J. Marion Sims and suggest that there is absolutely no loophole that he can get through. He was absolutely morally wrong. So those are the articles I'm working on. And finally, we're producing at Tuskegee a COVID journal. And so if anybody's interested, just tweet me, Twitter me, whatever you say. I don't know how that thing works. But anyway, send me a message. I'll send you the call for papers, because we are producing a one-of-its-kind COVID special edition journal. And there's a double byline peer review PubMed journal that you can get your work in to articulate the kind of views that you want to share with the world. Thank you very much again for having me.
Thank you. So very quickly, because we have just run over a little bit, I just ask the rest of the panelists. So Tony, do you have anything you want to plug?
No, well, I'm working on some AI patents right now, but due to the nature of the patent process, I can't really speak on it. So So I can't say much about that. But no, I enjoyed today. I was very impressed. I hope everyone enjoyed it. Thanks for having me. It was a good time.
Thank you, Tony. Jordan?
Yeah, no, other than my YouTube channel, which is just my name, I had a really great time, and thanks for having me.
And lastly, Dr. Doyle?
Again, thank you. It was a wonderful discussion. I'm on Twitter at Pain Gurus DC, and I have some work coming up addressing, some of the definitions we use and apply towards Black pain patients. And again, thank you.
Oh yeah, please follow. My name's below. Same name, Twitter and Instagram. Thank you. T Blizak is how you will pronounce it.
Okay, so thank you to everybody again. Thank you to all the participants that were here. Just to say a quick note that we do have a journal club on later. And it's at 5 p.m. EDT, which is 10 p.m. in the UK, which is just going to be 5 of us members of the committee talking about certain journals and dissecting them, especially to do with racial bias. And it will be a very interesting, quite informal conversation. But thank you again to all our panelists, and that concludes our discussion for today. Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.